Care coordination, as explained by the Agency for Healthcare Research and Quality, is an essential component of holistic patient care which involves participation and professional collaboration from an interdisciplinary approach to support continuity of care, thus bridging the transition from treatment in the acute clinical setting to assimilation back into the community. Some examples of beneficial care coordination activities include proactive assessment of patient goals, early consultation of appropriate interdisciplinary team members, securement of necessary assistive medical equipment for use in the home, communication with insurance companies for minimization and lapse of therapies, and referral to appropriate outpatient resources for follow-up and community support. By incorporating evidence-based care coordination practices into the clinical setting, patient-centered care can be optimized and higher levels of patient satisfaction can be achieved. The following audio recording will explore collaboration strategies for effective care coordination, ethical considerations for coordinated care planning, legislation and policy provisions affecting care coordination outcomes, and the nurse's role in the coordinated care planning process. When beginning to build a coordinated patient care plan, it is important to first become familiar with evidence-based strategies for care coordination which have been proven to optimize patient and provider outcomes through extensive research and evaluation. Some strategies that can be utilized by all healthcare providers to minimize lapses in continuity of care, as explained in a 2017 publication to the Annals of Family Medicine, include ensuring a thorough and in-depth assessment of the patient's medical history, giving them sufficient time to explain any health concerns and ask questions, including family members in meetings regarding new health conditions and care planning when permitted by the patient, and offering targeted health education when indicated. For example, if a provider is planning to treat a patient with chronic pain, but is not aware that they also have end-stage renal disease, they may prescribe them NSAIDs for pain management, thus leading to potential overdose, exacerbation of renal dysfunction, or additional health problems which could increase needs for care coordination and community support, including referral to dialysis treatment centers and home care nursing, for example. For this patient, consultation of a nephrologist, monitoring of lab work, and planning for continued follow-up in the outpatient setting may be indicated as a means of care coordination. In taking time to thoroughly assess this history, listen to all of the patient's questions and concerns, and offer education such as what pain medications are appropriate with a comorbid diagnosis of renal failure and what resources are available in the case of symptom exacerbation, the patient is cared for from a safer, more holistic, and more personal perspective. Referrals to appropriate interdisciplinary team members can be made from a place of education on the patient's history, and coordinated care planning is possible. As reported in this article, 60% of study participants reported subjective perceptions of poor care coordination when these assessments were not performed and education was not offered. Another strategy that can be utilized to promote care coordination is the adoption of evidence-based models of care planning into current practice to encourage early recognition of needs. As explained in a 2019 article published to the Journal of Interprofessional Education and Practice, one example of this model would be the CORE model. In the CORE model, patient histories of frequent hospital readmissions or clinical histories, including complex health conditions, are evaluated collaboratively by interdisciplinary team members to identify opportunities for referral and management with available community resources. Criteria for this interprofessional evaluation and referral through the CORE model of coordinated care planning and intervention include current treatment in the acute care setting, 2 or more readmissions to the hospital within the previous 6 months, as well as any 3 of the following conditions, including multiple chronic comorbidities, complex medication needs for health maintenance and management, clinically diagnosed mental illness, homelessness, current abuse of drugs or alcohol, absence of family or community support, or any other disability, be it mental or physical, that would limit a patient's ability to access available community resources. Patients who are deemed eligible for evaluation through the CORE model received targeted assessment and care planning in the acute care setting, home follow-up within 5 days of leaving the hospital, escort to follow-up appointments by CORE model team members, and weekly face-to-face follow-up for re-evaluation of needs and continued support until goals of care are met and they are deemed independently capable of utilizing available community resources for continued health management. In utilizing this model, researchers found that patients received 3 times greater effort, interaction, and support by healthcare providers in their care, and patients' outcomes were significantly improved related to increased activity and dedication in the execution of their coordinated care plan. Before coordinated care plans are built through utilization of these strategies, however, it is important for all of the interdisciplinary team members to have a thorough understanding of common responses to change which may be experienced by the patient. To do so, evaluation of the Kubler-Ross change curve, a theory which proposes 3 general, sequential stages of emotional response to feelings of loss or change in one's life, is beneficial. As explained by the Elizabeth Kubler-Ross Foundation, the first stage of the change curve is characterized by shock and denial. In the case of introducing a new chronic diagnosis to a patient, for example, this may be a poor time to attempt care planning, as the patient may not be receptive to goal setting and education. The most supportive action by the nurse and the interdisciplinary care team in general at this stage is to allow the patient to take time to come to terms with the diagnosis and accept this life change. Stage 2 of the change curve is commonly associated with fear and anger. As this life change is accepted by the patient and this new diagnosis becomes a reality, these feelings may arise as a result of feeling a lack of control. Communication is highly important at this stage in the change curve in order to ensure high levels of care quality and patient satisfaction. In practice, this may look like spending time with the patient and allowing them to discuss their concerns, reassuring them of the support that is available to them throughout this difficult time. The third and final stage of the change curve is characterized by feelings of acceptance and openness, and is the point at which the patient is most receptive to education and active care planning. By this time, the patient is ready to discuss positive ways to adjust to this life change. The nurse should now begin to encourage discussions including goal assessments, interdisciplinary consults, and connection with available community resources. And following this process and providing support in this manner, respect for the patient's normal response to change is maintained and patient outcomes are optimized. When the patient is ready to participate in active care planning along with the interdisciplinary team, care coordination activities can begin and decisions on follow-up programs and referrals to community resources can be made. However, when making these decisions, it is of utmost importance to maintain the highest level of ethical devotion to the patient, the healthcare organization, and the nurse's professional responsibilities. To do so, consultation of resources such as the American Nurses Association Code of Ethics with interpretive statements is beneficial to ensure actions being taken are in alignment with the nurse's ethical responsibilities. Some specific provisions of the American Nurses Association Code of Ethics which should be considered when coordinating care during the transition between the acute care setting and return to the community include Provision 1, which outlines an expectation for compassion and respect toward all patients, Provision 2, which explains that the nurse's primary commitment should be to the patient, Provision 3, which outlines the nurse's role as a patient advocate and responsibility to ensure their goals of care are met and their safety is maintained, Provision 4, which describes the nurse's authority and obligation to take actions and make decisions to promote the best possible patient outcomes, and Provision 8, which explains the nurse's ethical obligation to participate in interdisciplinary collaboration for care planning to provide the highest possible quality of holistic patient care. In incorporating these specific provisions into practice, the nurse effectively maintains ethical standards of care throughout the care coordination process by utilizing interdisciplinary collaboration to create a plan that meets the patient's goals, identifies available resources, and respects the patient's autonomy while advocating for their best interests from a place of mutual respect and compassionate care. As explained in a 2016 article published to the Home Health Care Now, these activities outlined with the American Nurses Association Code of Ethics are essential to building trust in the nurse-patient relationship, and nurses were seen as more trustworthy when they assisted in helping patients reach goals of care, spent time with the patients, offered respect, and supported continuity of care. This is to say, then, that in abandoning these ethical responsibilities in the care coordination process, possible consequences include loss of trust in the nurse-patient relationship, which could lead to negative outcomes such as lack of receptivity to change, education, and care planning by the patient. It is also important to consider specific healthcare policies applicable in the respective geographical care location when attempting to build a coordinated care plan, as specific legislation and policy provisions can determine what resources are available to certain patient populations for assistance during this transition of care. For example, consultation of the Centers for Medicare and Medicaid Services website can be helpful in educating the interdisciplinary team on existing policies which could be utilized to provide support to the patient when they return to the community. Medicaid, which was established by the Title 19 of the Social Security Act of 1965 and modified by the Affordable Care Act of 2014, provides health insurance for low-income populations. This is an important resource for the interdisciplinary team to be aware of when building a coordinated care plan, as knowledge of patient rights and access to this government-provided financial support could help to offer the client outpatient support and educational resources that would otherwise be unattainable given their socioeconomic status. For example, New Jersey Medicaid policy provision NJ-18-0010, approved on July 9th of 2021, presents legislation which allows individuals dealing with substance abuse disorders to receive treatment in settings such as intensive outpatient programs or IOPs, rather than only covering inpatient treatment. New Jersey Medicaid policy provision NJ-18-0003, approved on January 23 of 2020, approves coverage of a diabetes self-management education program, thus offering individuals with diabetes access to educational services which covers typical topics such as lifestyle changes, methods of diet control, and medical management in order to promote proactive self-care and an understanding of the disease process. Lastly, New Jersey Medicaid policy provision NJ-16-0002, approved on May 12 of 2016, offers access to home health services for children experiencing conditions such as developmental disability, abuse, severe disruptions in emotional processing, etc. By creating policy provisions which ensure access to these community resources for patients in this way, legislators effectively work to protect the rights of the patient and provide interdisciplinary teams with the tools necessary to offer the highest possible quality of patient care and promote continuity of care from the acute care setting back into the community. According to a 2019 article published to BMC Health Services Research, lack of access to this community-based care, as ensured through institution of this legislation, was associated with failure to seek follow-up care for identified medical conditions in 70% of patients lacking adequate healthcare coverage. Considering this, it can be reasonably concluded that some benefits of these community-based resources, as guaranteed through these provisions, include consistent follow-up care, early recognition of symptom exacerbations, prevention of hospital readmissions, reduction in noncompliance, and active utilization of available psychosocial support. And potential consequences when this support is not offered include frequent hospitalization, poor disease management, and lack of adequate health education. Ultimately, as noted by the American Nurses Association, the nurse's role in care coordination includes assessment of goals, patient advocacy, communication with the interdisciplinary team, connection with appropriate resources, and assistance in transitions of care. By working to make thoughtful, ethical decisions with support from available government policy and community resources, coordinated care plans can be developed to promote the delivery of the highest possible quality of patient care and the best possible patient outcomes in general.